as Dirk and I briefly debated in the Q&A afterward, I think there's really not a lot of controversy actually about this topic. There definitely does exist diffusion-weighted negative strokes. They're somewhat uncommon, but do occur. This is really only relevant to the mild stroke population, which of course is the highest proportion of strokes that we see. But the entity truly does exist. It's uncommon, but it exists. The scenarios that we typically see it in are situations such as posterior circulation stroke presentations, or patients without motor and speech symptoms, shorter duration episodes, or when people have repeated stereotypic spells. So those are sort of the conditions that we see it. One of the things that I really wanted to discuss with this presentation was how to minimize that scenario by optimizing your MRI sequences, by using high-resolution MRI, sagittal MRI, and also to image the brain later from onset rather than early. If you image the brain in the first 12 hours or so, you will see this phenomenon more commonly. But if you wait 36 hours from the onset of symptoms, it's pretty uncommon. So those scenarios. Why does it really matter, I think, is kind of the more important question for CONy, and that is the absence of a diffusion-weighted image, even when you optimize timing and sequences, really portends a fairly benign subsequent risk of recurrent stroke. And we typically will work up our patients to a less extensive degree on a more casual manner when the patients are DDY negative. If they're DDY positive or even have multiple DDY lesions, they're much higher risk and need to have more extensive investigations and more urgent investigations. So that's kind of the philosophy around this. It's not a matter of if it happens, it's how do you reduce its frequency? What does it mean? That kind of thing.